Hello, everyone. Welcome to yours and my favorite part of the week. That's right, it is your Psych, Culture, and Society online course, and I'm here to walk you through our next chapter, and that is mental health. So, with that said, let's jump into it. The overarching themes in this chapter: while some psychological disorders are universal, many are seen only in specific cultures. Culture plays a role in the triggers and the manifestation of psychological disorders, even universal ones. Let's begin, like we always do, by defining our terms. And like every term we attempt to define, it is not that easy, and there's always debates on the precise definition of a term. But again, we're going to operationally define it for the purposes of this class. And the definition is psychological disorders are described as behaviors that are rare and impair the individual. Problem: the definitions of quote rare and quote problematic vary across cultures and contexts. A disorder may be rare in one context, but not in another. Alcohol abuse in class is rare, but alcohol abuse at a frat party is not particularly rare. It may also be unclear what is considered problematic. The pianist Glenn Gould's musical talents were very rare and also interfered with his social life, but it's unclear if this was a disorder. So pretty straightforward here. We have this rare and problematic definition of mental health, or psychological disorders, I should say. And obviously, that depends on cultures, particular countries, but also historical eras. And you can kind of see this with the idea of addiction as well, just kind of giving you a little prelude, or a little foreshadowing, I should say. With addiction kind of requiring kind of a social cost, and people having that social cost, or that is the use of or doing something repetitively, kind of harming your social life. What is harmful to someone's social life is as can be debated across cultures and historical eras. So you can kind of see here with musical talents. So someone who's a great pianist, obviously being kind of obsessed with the piano and playing it constantly, and interfering with their social life or his social life. But to the degree to which that is a disorder, or more broadly stated, kind of, or more specifically stated, addiction, is unclear. Culture-bound syndrome: a group of psychological symptoms that is greatly influenced by cultural factors and occurs far less often or is manifested very differently in other cultures. The cultural concept of distress. So what we're getting here, and this kind of goes back to really chapter 1, is the degree to which these psychological disorders are universal, and that involves how the prevalence of that disorder existing across all theoretical cultures, but not just them existing across all cultures, but kind of the degree to which it exists. So kind of the accessibility of psychological disorders. That is it incredibly common, or is it a very rare case to have a particular psychological disorder within different cultures? And we're going to begin with Dot syndrome. Experiencing a culture-bound syndrome generally requires one to have cultural beliefs associated with the syndrome. In Southeast Asian cultures, Dot syndrome is a morbid anxiety seen most frequently among South Asian males. It involves a belief that they are losing or leaking semen, which makes them anxious because they consider semen to be a source of vitality and believe that excessive loss results in serious illness. This syndrome is often associated with crippling feelings of guilt and anxieties after indulging in disapproved sexual acts such as masturbation. This Dot syndrome would be meaningless in the context of the U.S., however, where there are no cultural beliefs or few cultural beliefs about the vitality that sperm endows or about the consequences of loss of sperm. In other words, being susceptible to Dot requires relevant beliefs that relate semen, sexual activity, morality, and health. So, as stated, kind of the idea here is that you have to have a belief in the existence of this syndrome, and kind of like these other presumptions about the association between kind of certain objects or certain biological processes, or kind of statistical terms. You have to have particular priors about these association between certain objects. So in this case, the association between morality, health, and sexual activity, making the or I should say, increasing the likelihood of this syndrome existing within particular areas, because the association between morality, health, activity, and the meaning of losing or leaking semen is varies across culture. Thus, in cultures that kind of have those priors, those assumptions, those beliefs about the association between those objects or those kind of or those understandings of morality, place those populations at greater risk of acquiring or that syndrome being present within their society, and in this case specifically South Asian cultures, in particular men. Hikikomori, which loosely translates as, quote, pull inward, and refers to social withdrawal. This is a condition in Japan characterized by living in an asocial state, with no intimate relationship with anyone outside the immediate family for at least 6 months. It includes not participating in school or a job during that time. It first appears in junior high/middle school, depending on your generation or what country you live in, when sufferers end up reading books, watching TV, or playing games in their rooms. They drop out from the social world, often barricading themselves up in their room, sometimes even for years. There are indications that the cause may be failure to succeed in a social world that has few options for those who don't fit in. The social cultural factors may contribute, including strong social pressures and eroded career opportunities. Researchers estimate that 1% of Japanese may suffer from the condition. It does not conform to any other set of symptoms in the DSM-5. There are significant numbers of people with similar symptoms in South Korea and Taiwan, and occasionally there will be a case with parallels to hikikomori in Western countries. It appears to be largely a unique syndrome in Japan in terms of its presentation and prevalence, however. It is possible that other cultures suffer from the same psychological disorders as the West, but don't have the same cultural beliefs associated with Western diagnosis, which makes them culturally meaningless in other cultural contexts. So, kind of getting at the last question here, which asks, I should say, and really gets at the idea that without those understandings of or certain beliefs associated with particular syndromes, that cultural bound syndrome theory, is it possible that those mental psychological disorders outlined in the DSM may exist in other cultures, but because they do not share those same cultural beliefs associated with those particular diagnoses, it thus kind of makes it meaningless in that culture, and thus they don't kind of describe it as a psychological disorder. And in this case, you can even see kind of going the other way with the DSM-5, which for those who are unfamiliar with it or kind of just forgot, it stands for the Diagnostic Statistical Manual of Mental Disorders, and there's basically this is the 5th edition of it, and the DSM-5, which is created in the United States and predominantly used in the United States. However, there's some cross-cultural usage in other countries. However, other countries have their own manuals or more kind of international manuals. And specifically, kind of the DSM-5, which most of you would be familiar with, or most would be more likely to be familiar with than other international manuals of mental disorders, does not have this classification or does not list hikikomori as a psychological disorder. So kind of again, this cultural bounds culture impacting kind of the identification and diagnoses of particular psychological disorders within specific cultures. And kind of just to review, I stated for this the symptoms associated with this psychological disorder, it's really kind of this pulling in, the kind of isolation from the other people within your family, your friends, so kind of a removal of yourself from kind of your in-group, which thought to be influenced or predicted by, or at least associated with, kind of eroded career opportunities, kind of just like kind of a failure in the eyes of this person to live up to expectations, or kind of really have kind of having a dignified life, in the absence of the living a dignified life, kind of this kind of giving up for some X amount of period of time, wherein you focus really, you self-isolate in response to living a life without dignity, and or kind of imagining yourself as kind of a social outcast, not being able to like make it in this world. And you and some people kind of argue that this could be related to a shift, which really kind of these global shifts, as we talked about before, with kind of a mass across scale and across the world, kind of increases kind of individualism and kind of this mono capital culture that's existed, kind of which kind of strips away kind of cultural kind of protective factors, while at the same time kind of introducing new social obstacles and stressors within one's life. Eating disorders. The two most common eating disorders are bulimia and anorexia. The estimates for rates of eating disorders were once as high as 19% of American university females. However, using more stringent criteria, the estimate is around 5 to 7%. Rates for both disorders have increased dramatically in the last 50 years. Symptoms of these conditions are relatively consistent cross-culturally and within cultures. Bulimia is a disorder characterized by recurring episodes of binge eating, which refers to eating unusually large amounts of food within a 2-hour period, feeling the lack of control over this eating, along with inappropriate behaviors to prevent weight gain, that is, induced vomiting, laxatives, excessive exercise, occurring at least twice a week for 3 months. Bulimia appears to be a cultural-bound symptom because rates have increased over time, and the age of people being diagnosed with bulimia have gotten lower over the years. More prevalent in some societies, particularly those with Western influence than others. It is absent in most cultures of the world, especially in cultures where food is not abundant. There is good evidence that bulimia is a culture-bound syndrome. So we see here that the definition of psychological disorders obviously will have an impact on the estimates of how many people suffer from the disorder. We also see that the influence of kind of Western influence on the prevalence of bulimia, and kind of the argument that in cultures that where food is not abundant, this kind of process of bulimia, that is kind of eating, binge eating, and then preventing weight gains through vomiting, laxatives, and kind of excessively exercising, either not existing or being very rare in cultures where food is not abundant. And, kind of that just makes social sense, just on a, just kind of thinking it through, that it could be kind of a risky proposition to kind of eat all your food and then expel it. But also maybe it can be related to different kind of ideas of the idea of what individual control means, and what a lack of control means, that kind of conceptualization on how much control and decision making people have in their daily lives, kind of maybe contributing to different prevalences of bulimia across cultures. Anorexia is a disorder in which, among other symptoms, one refuses to maintain a normal body weight, is irrationally fearful of gaining weight or becoming fat, and denies the seriousness of abnormally low body weight. It's a little more complicated whether anorexia is culture-bound. As with bulimia, rates of anorexia have significantly increased over time, and it is absent in many cultures. It is found in cultures that have very little Western influence, and it also manifests differently in some other contexts as well. There's evidence of anorexia in places with relatively less Western influence, such as the Caribbean island of Curacao, Iran, and South Korea. In Hong Kong, people diagnosed with anorexia often do not have a fear of weight gain, which is a key symptom in the West. Instead, they may say they stopped eating because of lack of appetite or because they feel bloated. Symptoms resembling anorexia have also been noted among ascetics who refuse food for religious reasons, and in the 17th and 18th centuries among teenage girls who start themselves to emulate ascetic medieval saints. This historical record of anorexia, as well as evidence of anorexia in many non-Western cultures, have led some to argue that it is a universal disorder, although it may serve different functions in different places. That is, religious reasons versus weight loss reasons. Overall, some symptoms of anorexia appear universal, but they are still influenced by culture. So this comes back to kind of this chapter 1 conceptualization and kind of the ladder, the stages of universality, or kind of purely culturally derived any psychological phenomenon, in this case psychological disorders, obviously. And in this case, kind of the general idea here, the current kind of argument is that some symptoms of anorexia being universal, but they're still influenced by culture, and that, as you can see in Hong Kong and just different countries, or in other countries as well, the symptoms and the reasoning behind anorexia differing across cultures. And those differences can be related to secular versus religious reasons, and differing kind of physical symptoms as why they are not eating at this moment, or keeping an abnormally low body weight, such as feeling bloated, or having a lack of appetite in individuals in Hong Kong. So we have anorexia kind of existing in many cultures, but also being absent as well. It's not present in all cultures, and the reasoning for kind of practicing these abnormally low rate practices kind of differing by culture, or being influenced by culture, and even at historical eras, as we saw with kind of this emulation of medieval saints. Koro, which means head of turtle, manifests in men as morbid anxiety and fear that their penis is shrinking into their body, primarily found in South and East Asia, particularly southern China. There have been cases of Koro epidemics, as in 1967 in Singapore, following an epidemic of swine flu. It led to widespread inoculation of pigs, and later rumors spread that Koro could develop from eating inoculated pig meat. Hospitals were then overwhelmed with people presenting Koro symptoms. Because Koro is nearly absent in most cultures except South and East Asia, it meets the criteria for a culture-bound syndrome. It's unclear what aspect of culture have led to its emergence. Some argue that that Koro is grounded in a classical Chinese medicine belief that imbalance of yin and yang can cause the genitals to retract. Yet Koro-like symptoms have been found in some individuals in West African cultures, as well as in individuals in American cultures who have had negative marijuana-induced experiences. Some components of Koro may be universally accessible, but they only seem to manifest clinically in cultures where people are aware of its existence. So kind of the idea here, as kind of stated in the last bullet point, some components may be universally accessible, so something like anxiety or male anxiety being universal, or being at higher rates of universality, but them this kind of Koro developing, or it becoming this clinical psychological disorder in cultures that are familiar or know or are aware of the existence of Koro. So again, kind of this knowledge of Koro and kind of the association between, in this case, genitals and kind of yin and yang theory. In this case, there's one argument of kind of a conceptualization of cultural understanding of particular medical practices and how they relate to just specific parts of the body, contributing to the likelihood of particular psychological disorders emerging or being panicked about. In this case, Koro. Next, ataque de nervios, which is a broad array of symptoms, including convulsions, partial loss of consciousness, heart palpitations, numbness, sudden outbursts, sense of heat rising to the head. One of the most studied cultural bound symptoms, and documented since the 1950s, It typically occurs within a couple of days after a stressful event, such as a serious family conflict or death in the family, especially after experience with violence. It's usually brief, can happen across the lifespan, and more common in women. It's viewed by Latino mental health professionals as a culturally recognized means of communicating strong emotion and protesting unfair treatment, particularly within family relationships. Symptoms of overlap somewhat with panic disorder, but majority of those with ataque de nervios do not meet criteria for panic disorder diagnosis. So kind of just for simplicity's sake, I'll just say a DN here. So we have kind of this disorder identified since the 1950s that's viewed by medical professionals within those countries, those cultures, as a real psychological disorder, and is not specifically to bringing light to or kind of protesting, as stated, unfair treatment. And you can even see here again kind of the differences between interdependent selves and kind of the role of the family and the contributing to the possibly contributing to, I should say, the likelihood of this or the emergence of this culturally bound syndrome within Latino communities. And in general, because women are typically at higher rates victims of kind of family violence. It would kind of be expected that if this is a kind of response to unfair treatment or even violence within family units, women kind of being more likely to develop ADN. But also, as stated, this can also occur in response to a very kind of traumatic event, more generally, within a family context. Amok, sudden outbursts of unrestrained behavior or violence preceded by brooding and ending with exhaustion and amnesia, most common in Southeast Asia, may result from having no culturally acceptable means to express frustration, and thus some people explode in an uncontrolled fit of anger and unresolved tension. The pattern of symptoms and cultural meaning that appears are specific to certain Southeast Asian cultures. Some argue that there are parallels between this and Western mass homicidal attacks, such as school shootings, workplace killings, etc., although they make the distinction that Western ones are premeditated. It is unclear whether these similar behaviors have a common underlying disorder. So there's kind of attempts and arguments for some arguments of kind of drawing links between amok and kind of Western homicidal attacks. But kind of a large distinction is that in general, Western mass homicidal attacks are premeditated, while amok is thought to kind of be, again, kind of this uncontrolled, unrestrained behavior that is not premeditated and then followed by symptoms of amnesia. Hysteria. Hysteria involves symptoms such as fainting, insomnia, temporary blindness, loss of appetite for food or sex, and general disagreeableness. This was in 19th century Europe. Rates of hysteria diagnosis dropped dramatically in the early 20th century. Some argue this is due to it being replaced by other diagnostic categories, while others think it was associated with repressive Victorian cultural norms. It could be understood as either a cultural bound syndrome, differentiated across historical periods, or as a reflection of changing classification in psychiatry. So, as stated in the case of hysteria, differences in the cultural bound nature of it could be linked to differences across historical periods, where in European Victorian societies, kind of cultural norms associated with those with that culture in the Victorian era of kind of like modesty or kind of repressed sexuality in women, kind of contributing to the likelihood of this psychological disorder being diagnosed within that historical era. But also it could also reflect kind of changing classifications in psychiatry with different new psychological disorders emerging or being kind of identified that more accurately classifies the particular disorder that an individual is experiencing. Now I'm just going to jump around a little bit, just pointing out a few of these other culturally bound disorders. Susto, a frightening condition in which people think their soul has been dislodged from their body, resulting in a variety of physical and psychological symptoms, primarily found in Latin America. And again, kind of jumping a little forward, the Malgris, people's belief that they have been invaded by a totemic spirit, it's kind of like animal spirit, that makes them physically sick or drowsy because they entered the sea or a new territory without having engaged in appropriate ceremonial rituals, identified among Aboriginal Australians. Again, jumping ahead, Kufun Gi Sisa, anxiety and somatic problems associated with mental exhaustion stemming from too much thinking, translates as thinking too much. It comes from Shona, a language spoken in Zimbabwe. Because people feel their mind has been damaged by fatigue and can no longer function properly, they experience panic attacks and irritability. Found in Africa, the Caribbean, and among Native Americans and East Asians. All right, so that's basically what I'm going to cover for culturally bound disorders, and kind of in this case, these final three, you can kind of really see here kind of the views of the soul, of kind of spirits, animal spirits, kind of your understanding of deities, territory, and kind of thinking too much, how much you should be thinking, kind of like self-absorbed, or kind of arguably self-absorbed, according to these cultures, to an extent that you can't even really function within a community setting, impacting the prominence and the diagnoses of psychological disorders within specific cultures. Universal conditions highlight the biological foundation of mental illnesses. The prevalence and manifestations of these disorders may differ quite dramatically across cultures. So now we're going to kind of talk about universal conditions that, again, as stated, kind of highlight we're all humans and the biological foundation of mental disorders. Beginning with depression. Depression is one of the most commonly identified psychological disorders in the West. The DSM-5 list major depressive disorder, MDD, is diagnosed given when 5 of the following 9 symptoms, including at least one of the first 2 for 2 weeks or longer. And I'm not going to read all these, but kind of the idea, these are the symptoms, and you have to have at least one of the first 2, and 5 out of the 9 as stated, and they have to last for at least 2 weeks. MDD has been found in all cultures that people have studied, although rates of prevalence appear to vary. The rates of prevalence of depression vary in the U.S. based on the diagnosis criteria used. Some surveys found rates of 5% to 17% in under less strict criteria. Rates were as high as 44% at a given time. Rate in China is about 1/5 that observed in the United States, and some non-Western cultures have higher rates in the West. Nigeria, for example, has 4 times the rates of MDD than the U.S. rate in 1999. So here we have cultures that have been studied, MDD being found in all cultures that have been studied. However, the rates vary, and you can see that also I should say that depending on kind of the definition of the criteria used, they can be radical fluctuations in the percentage of diagnoses of MDD. But as stated, the diagnosis or the amount of people in surveys who are identified within medical settings as having MDD varies across culture, with China having about 1/5 that rate of the United States, but in some countries, some non-Western countries, such as Nigeria, having approximately 4 times the rate of the United States. And obviously we have kind of a case wherein individuals may underreport their rates of depression, and that could differ by culture, kind of the motivation to underreport them. But the specific motivation underlying all the different cultures are beyond my expertise. So, for example, why specifically Nigeria or other particular African communities have more or less rates of MDD is typically not fully understood and kind of beyond the scope of kind of this brief overview of these psychological disorders. bipolar disorder, characterized by depressive episodes and also manic episodes with hyperactivity and extreme euphoria, and optimism that impairs judgment. Prevalence rates vary around the world. They're highest in English-speaking countries such as the United States and New Zealand, and lowest in South and East Asia. There's less cross-cultural variability in prevalence rates of bipolar disorder than those of depression. And the cross-cultural differences in bipolar disorder are not as well understood. So what I mean by cross-cultural variability and less cross-cultural variability is how you saw it kind of on the previous slide, with China having 1/5 the amount of MDD and Nigeria having 4 times the amount of MDD as both the United States as kind of that reference group. Less variability kind of meaning that the rates of bipolar disorder across cultures being more similar or being more crunched together. There's less variability in that data, that diagnosis of bipolar disorder as compared to MDD. So kind of just like a quick overview of this order. Kind of the idea here is that you're extremely high sometimes, extremely low sometimes, but when you're extremely high, it's not just like, whoa, I feel like great. Or it's just like you are so irrationally euphoric that you believe you can do anything. You can hike 9 mountains in one day, and you put yourself kind of in danger. And the degree to which you're in those depressive episodes and manic episodes are not the same length of time, the duration, I should say, of being in a depressive and manic episodes are not the same. Some people have longer depressive episodes than manic episodes, and vice versa. Depressed individuals may exhibit different symptoms. Depressed white Americans show exaggerated emotional responses. Depressed Asian Americans show exaggerated responses to the same emotion-eliciting stimuli. The cultural variability in types of symptoms, or the way they are manifested, there are kind of 2 dimensions. Somatic or somatization, I should say. Symptoms are primarily physical, such as loss of appetite, psychologization. Very easy to say. Symptoms are primarily psychological, such as depressed mood. So basically we have physical and we have psychological. And so in this instance with depression, we have depressed individuals expressing their symptoms in different ways, with, as stated, kind of white Americans citing on average being more likely to show decreased emotional responses to stimuli, while Asian Americans showing exaggerated responses to the same emotional stimuli. And it's interesting because we talked about in previous classes that in general kind of Americans more broadly kind of being more expressing their emotions at higher rates and kind of reacting at higher rates, and kind of Asians or I should say East Asians kind of their cultural practices kind of being manifested in the kind of more subdued approach to emotional responses or emotional expression. And in this case here, maybe kind of there may be kind of a generational effect, wherein white Americans, who are typically, and kind of just Americans more generally, more likely kind of show in general higher rates of emotional responses and being more emotional in general. So being depressed means that you lose some of that emotional responsiveness, while in general East Asians showing decreased or daily lives kind of having relatively decreased emotional responses, decreased levels of like intense emotion expression, and then in this case showing exaggerated emotions, so kind of the opposite. Of course, this is Asian Americans and not East Asians, but maybe kind of those you can imagine kind of a family unit wherein East Asians, maybe they're first generation or second generation East Asians, but having older relatives within a family unit, kind of still having those emotional representations or presentations of themselves, maybe manifesting themselves in different ways in which suppression manifests itself within this particular expression of emotions. Neurasthenia. Many Chinese psychiatric patients are diagnosed with neurasthenia. This syndrome includes more than 50 symptoms, including fatigue, poor appetite, headaches, insomnia, back weakness, hysteria, and inability to concentrate. The symptoms are more physiological than psychological. Neurasthenia was dropped from the DSM in 1980 because the symptoms were considered less important than the underlying illness. Chinese who fit criteria of neurasthenia, but not the criteria for depression, respond well to antidepressant medication. Some argue that most Chinese diagnosed with neurasthenia could be described as suffering from a clinical depression, even though only 9% of them report depressed mood as a key symptom. So kind of as I alluded to in the previous slide, we have different dimensions and types of symptoms. We have those physical symptoms, those psychological symptoms, and we have different ways in which depression manifests itself and expresses itself in different individuals, with white Americans showing decreased emotional responses, Asian Americans showing exaggerated responses to the same emotional elicited stimuli. And kind of the idea here is that for neurasthenia, the symptoms of this psychological disorder are more physiological than psychological. And both of those points kind of brings us to this slide, universal conditions. A variety of research methodologies have converged on the same finding, that Chinese and other East Asian patients exhibit more physiological symptoms than psychological symptoms compared to Western patients. This is certainly the case with depression. Why is there a cultural difference in physical versus psychological symptoms? One explanation is a concern about stigma. Everyone experiences the psychological symptoms, but Chinese people are less likely to report them due to fear of being stigmatized. Koreans who describe the distress in physical terms receive more empathy than those using psychological terms, a pattern that did not hold for Americans. There's the same tendency to report more physical symptoms among East Asians in both private and public responding. This suggests that there may be more to this cultural difference than social stigma. The second explanation suggests that even if the experience of depression is the same, Westerners are more likely to focus on and notice psychological symptoms, whereas East Asians are more likely to tend to their physiological symptoms, thus reporting more of these. This is despite the fact that both types of symptoms exist for both cultural groups. The data seems to generally support this explanation. For example, Chinese psychiatric patients pay less attention to their emotional states than Westerners, and this difference predicts cultural differences in physical symptoms. All right, so as I stated, East Asians in general are more likely to exhibit more physiological symptoms and psychological symptoms in depression, and there's kind of a couple competing theories why this is the case. One argument is that this is just due to social stigma, and East Asians are experiencing the same amount of psychological symptoms, but they are kind of ashamed to kind of express those psychological symptoms or talk about them because of stigmatization. However, when looking at data from both private and public responses to symptoms associated with depression, East Asians report the kind of same levels of physical and psychological symptoms associated with depression, no matter if it's private or public reporting, which kind of suggests that it's not this public pressure that is contributing to this cultural difference, but maybe something else. And the second kind of argument is that both groups are experiencing the same amounts, or at least kind of the same, both are experiencing both physical and psychological symptoms associated with depression. However, East Asians are more likely to attend to their physiological symptoms. And kind of evidence pointing to this argument is that psychiatric patients, Chinese psychiatric patients, paying less attention to their emotional states than Western psychiatric patients, and kind of the difference in this attention to particular emotional states, in this case paying less attention to psychological states, predicts cultural differences in reported physical symptoms associated with depression. So kind of really kind of just a focus, it's the argument is a kind of a focus on individual emotions, or really kind of the self emotions, kind of that paying relatively less attention as compared to Westerners on individual self emotions, contributing to the difference in cultural differences in physical symptoms being relatively less cited in Chinese samples or Chinese psychiatric patients or Chinese depressed individuals as compared to Westerners. So kind of really a difference on focusing on emotional states contributing to the self-reported psychological and physical symptoms associated with depression in different cultures. Social anxiety disorder: fear of acting in an inept and unacceptable manner, and that such behavior will lead to disastrous social consequences. It's documented universally, reflecting universal concerns that we share as social beings. There are, however, some cultural differences. For instance, there's a higher experience of symptoms in East Asians. Asian Americans report more social anxiety symptoms than white Americans. There is also a link between interdependence and heightened social anxiety symptoms, while independence is associated with less discomfort in social situations. It suggests that there is a cultural connection between social harmony and the experience of social anxiety. However, there is a lower perception that social anxiety is problematic in East Asian countries. Extreme shyness is perceived less negatively in Asian contexts than Western ones. One study showed that Chinese children who were evaluated as shy were viewed more positively by peers and teachers, whereas Western children evaluated as shy were more likely to be rejected by their peers. All right, so here we have a previous literature suggesting a link between interdependence and heightened social anxiety symptoms. Again, kind of a social anxiety disorder being characterized as kind of unacceptable manner that's creating devastating social consequences. So kind of just the basic understandings of interdependence that we've learned about in this class, that we're connected together, that one individual's behavior kind of affects kind of the state of other people's behaviors and personalities and just kind of general world outcomes kind of are bound together in this kind of fragile social harmony. So, kind of based on kind of that background, it kind of makes sense that you would suspect, and studies kind of support the idea of this link between interdependence and heightened social anxiety symptoms, while independence is associated with less discomfort in social situations. So, kind of the idea, kind of going back to our basic understandings of independence, selves. Kind of I'm acting in my own individual interests. I'm unaffected by other people. My personality is bounded within myself. And I'm not, and I can leave social circumstances whenever I want. I do have friends, but it's not like they're gonna super kind of dictate the trajectory of my life. Thus, maybe I feel less discomfort in social situations, or I feel less nervous about creating a circumstance wherein there are social consequences for other people, because I'm just pursuing my own goals and I'm unaffected by those social consequences of others people. And this is kind of going back to the idea also of social harmony being linked with social anxiety. However, interestingly, there's also, so we have kind of this link between interdependence and heightening social anxiety symptoms. However, the understanding of those social anxiety symptoms is different across cultures, wherein the perception of social anxiety is lower, or the negative impacts of social anxiety is perceived less than kind of Western countries, where, again, kind of this independence is higher rates. And some studies have demonstrated that extreme shyness is perceived less negatively in Asian contexts than Western ones. And in fact, some studies suggesting that Chinese children who were evaluated as very shy being viewed as more positively with peers and teachers, while in Western cultures, shy being kind of associated with more likely to be rejected by peers. And this could be facilitated by the idea that this kid here is kind of socialized at a quicker rate. They're acting within our cultural norms. They're upholding social harmony, and kind of that is kind of a cool thing to do, within that cultural context, which is going to be different than the United States, where kind of cool thing is, kind of going your own way and pursuing your own kind of goals. and kind of expressing yourself at higher rates. Thus, kind of those differences possibly contributing to the perceptions of the issues associated with social anxiety. There is a paradox of East Asians experiencing more symptoms but not meeting the clinical criteria for social anxiety disorder. This may be due to differences in what behaviors are considered culturally normative. In Western cultures, the norm is for people to be extroverted. In East Asian cultures, the norm is for people to be introverted. Because social anxiety is viewed as less problematic in East Asian countries, it may be that people are less troubled by having social discomfort when it's common to be concerned about interpersonal relationships. Note that clinical diagnoses need to account not only for symptoms, but also for perceptions of what is normative. So as I outlined in the previous slide, different cultural practices, different views of the selves and how they interact with the world, different understandings of like kind of control and kind of individual autonomy, contributing to how the culture views a psychological disorder, or if it's a psychological disorder at all, and kind of that's the last bullet point. So it's not really just only the symptoms of a psychological disorder, but also a clinical diagnosis has to account for the perception of what is considered normative within a particular culture. However, that's not to say that social anxieties do not become a problem in East Asian cultures. There's a cultural bound disorder found in East Asian countries that is similar to social anxiety disorder. Taijin Kyufosho, TKS, which was identified by a Japanese psychiatrist in the early 20th century, loosely translated, the term means fear of confronting others. It is a fear that is elicited by social situations. Both people diagnosed with TKS and those with social anxiety disorder respond favorably to the same antidepressant medication. However, symptoms of the two disorders are different. Social anxiety, people tend to worry about embarrassing themselves in social situations and that everyone will discover their faults. TKS involves physical symptoms, such that one is concerned about how uncomfortable one makes other people feel, perhaps because of their gaze, body odor, or sweating. Distinct enough from social anxiety disorder and rare enough outside East Asia, thus far limited to Japan, China, and South Korea, that is often considered a cultural bound syndrome. Here we can see, kind of going back to a few slides ago, kind of the difference between physical and psychological symptoms of a psychological disorder, in this case TKS, in some East Asian cultures, specifically South Korea, Japan, and China, having kind of similar symptoms of social anxiety disorder, but in the case of social anxiety disorder, people being is associated with people being worried about embarrassing themselves in social situations, discovering their faults, kind of imposter syndrome kind of esque kind of idea, versus TKS, which is more involves physical symptoms and kind of is as we talked about, kind of in line with other disorders, and specifically depression, wherein East Asians being more likely to report physical symptoms. In this case here, also TKS involving physical symptoms, specifically body odor, sweating, gaze, and kind of those physical symptoms of somebody making of oneself, making others feel uncomfortable due to whatever their odor or how the way they're looking at somebody, etc. Schizophrenia, a disorder that is diagnosed when one exhibits two or more of the following symptoms: delusions, hallucinations, disorganized speech, catatonic or grossly disorganized behavior, negative symptoms such as flat affect or loss of speech. It is one of the most debilitating and prevalent mental disorders. Genetic factors, prenatal experiences, and neuroanatomical features are evident in schizophrenia, and the biological basis of schizophrenia is better understood than that of other mental disorders. And it's important to note that there are different subtypes of schizophrenia, which we'll cover in a couple slides. As stated, the biological basis of schizophrenia is relatively better understood than other mental disorders. Evidence of the genetic component of schizophrenia because one's likelihood of developing schizophrenia increases as the degree of genetic relatedness with someone who has schizophrenia increases. That is, only 1% of the general population will develop schizophrenia. But having a cousin with that disorder leads to the likelihood of a 2% chance of developing schizophrenia. Having a sibling with schizophrenia increases the likelihood of 9%, and having an identical twin increases the likelihood of developing schizophrenia to 48%. The incidence and prevalence rates are quite similar across different cultures. Despite the role of genetics, there's still more than 50% chance that someone will not develop schizophrenia, even if their identical twin, with whom one shares 100% of genes, has schizophrenia. That is, despite biological basis of schizophrenia and similar incidence rates across cultures, some cultural variation still exists. The universal criteria developed for several large studies excluded those who were mentally ill but did not meet them. This means that the similarity of symptoms in people diagnosed worldwide was partly a feature of the methods used. If people experienced different symptoms, they were not included in the study. So kind of the idea here is just with the increase of risk of developing schizophrenia, with the depending on the genetic relatedness to someone who also has schizophrenia, suggests that there's a genetic basis for schizophrenia. However, the fact that still around not even 50%, but whatever, you can even say 50% of identical twins, when one develops schizophrenia, there's still only a 50% chance, or a little under 50% chance, that they also will develop schizophrenia. Thus, this is there's a cultural thus suggests that it's not just genetics driving the development of schizophrenia. Also, the kind of idea here is that similar rates of schizophrenia have been found across many cultures. However, this may be kind of a measurement issue wherein the researchers kind of developed this universal criteria of schizophrenic symptoms and excluded other mentally ill individuals who did not have did not meet those specific universal criteria. Thus, it may have been kind of like a sorting out process wherein other cultures may have particular schizophrenic symptoms present in their culture, but not others, and thus that could kind of influence the rates of schizophrenia found across cultures. That is, if an individual who may had schizophrenic symptoms, but those people, or may have schizophrenia, but they did not have the specific symptoms outlined within that study, they were excluded from the study. One important line of evidence suggesting the role of culture is in the cultural variability in the prevalence rates of different subtypes of schizophrenia that people experience. And I should also say kind of environment, just like more generally. Paranoid schizophrenia, characterized by delusional visions, is most common in most places, but more common in the West. So I should just say is more common in the West. Paranoid schizophrenia characterized 75% of cases in the UK. In contrast, catatonic schizophrenia, characterized by absence of motor activity and insensitivity to stimuli, is very rare in the West. It has a prevalence rate of approximately 1 to 3% in the US and the UK, but in India has a prevalence rate of approximately 20%. So, kind of again, this onset of or cultural variability in the prevalence of different subtypes of schizophrenia suggests some kind of environmental effect, and more specifically, kind of a cultural effect on the prevalence of subtypes of schizophrenia found across cultures, with paranoid schizophrenia being the most common type of schizophrenia found in the West, versus catatonic schizophrenia, which in India you can see, has a prevalence rate of approximately 20%, which is about 20 to 7 times larger than the rates of catatonic schizophrenia found in the United States and the United Kingdom. This could suggest that different rates of the symptoms associated with schizophrenia are there's cultural variability, I should say, in the types of symptoms associated with schizophrenia. Again, those symptoms being delusions, hallucinations, disorganized speech, catatonic or grossly disorganized behavior, or kind of loss of speech and flat affect. And this kind of gets back to the point of the previous slide where we talked about these universal criteria of schizophrenia and kind of trying to establish what the rates of schizophrenia are across cultures. And kind of the findings from those studies may be impacted by the choices of criteria and who to exclude from the study. That is, if people experience different symptoms and they're not included in the study. It's interesting to note that patients in post-colonial societies have greater rates of recovery from schizophrenia than those in more industrialized societies. That is the opposite of what one sees with other physical and mental conditions. The cause of this difference is not known. Explanations for this counterintuitive pattern include lower sense of personal control in less developed, or I should say, lower wealth societies, thus more acceptance of people with schizophrenia, hallucinations and belief in spirit possession more common in less wealthy societies, so this may not be considered abnormal for people to hear voices or experience possession. Strong sense of community common in less wealthy countries provides supports. There may be greater involvement of the community so that people do not get left alone. Patients are more likely to remain members of the communities and societies rather than becoming homeless in industrialized societies. Note that these possible explanations are largely speculative. So what I mean by post-colonial societies is kind of really those that era of the 1950s, 1960s, where you just see a huge increase in the amount of countries being kind of freed from kind of colonial relations. So kind of those societies is what I'm talking about in general, having greater rates of recovery from schizophrenia. And it's kind of counterintuitive, and some of the speculative reasons why, and again, this is largely speculation. It could be that symptoms associated with schizophrenia are not viewed as abnormal in those cultures because of views of spirituality and kind of general feelings of personal control within one person's self and an environment. But also maybe a stronger sense of community, providing some kind of buffering effect of schizophrenia, wherein kind of integrating these individuals into their community and really, well, I should say, kind of remaining, keeping these people as kind of continued contributors to the community, rather than becoming homeless or kind of disowned. Like in industrialized societies, or kind of having a less likelihood of that occurring in kind of post-colonial or less wealthy countries, maybe contributing to some kind of buffering effect of the symptoms associated with schizophrenia, and alongside, again, kind of views of what is abnormal, maybe impacting the quote-unquote recovery from schizophrenia in these cultural contexts. Suicide rates and motives. Suicide is recognized across cultures, but its frequency rates vary dramatically around the world. It also appears to be triggered by a wide range of conditions. Eastern Europe tends to have the highest rates, while Muslim nations tend to have the lowest rates. Suicide rates also vary depending on one's age, with the elderly generally being more likely to commit suicide in most cultures. There was a special case in Micronesia in which there was a spike in the adolescent age group. It started primarily in the 1970s, with a spate of suicides occurred among adolescent men over seemingly trivial problems with no obvious psychological issues to begin with. Suicides were also restricted to specific islands, particularly the suburban regions of those islands. Some have suggested that the spike was due to westernization of the island, which led to a loss of traditional roles of young men and were part of a series of copycat suicides. So kind of just looking at this Micronesia example, being a special case where an adolescent's age group had higher rates of suicides than elderly individuals, and for kind of seemingly trivial reasons. And it was suicides were restricted to specific islands within Micronesia, particularly the suburban regions of these islands. And some argue that it was due to westernization of the island and kind of a loss of traditional young roles for young men. And this is kind of like similar to the argument that I laid out with the Japanese social withdrawal, kind of these big shifts in the culture of economics and politics of these cultures and then of these countries, and then leaving people kind of behind, and kind of what are the mental consequences and physical consequences of kind of those shifts, those large kind of those macro structural shifts. And in this case, kind of the suburban regions of those islands suffering the most. And so kind of maybe having that kind of cliche suburban neurosis, kind of anxiety about weird small things, and kind of the typical cliche neurosis of kind of middle-class suburbia, maybe contributing to kind of higher rates of suicide, alongside kind of the decrease of the buffering effects of traditional cultural just kind of protective factors, and maybe even traditional roles for young men within society. So kind of this larger shifts in gender roles, of economics, of politics, etc., kind of contributing to these developmental outcomes, in this case, suicide rates. Losing connection between one's cultural narrative in modern society, lack of cultural continuity, seems to put people at risk for suicide. Similar concerns have been raised among many native populations in westernized nations, such as the First Nation bands in Canada. Suicide rates of First Nations adolescents is 5 times that of mainstream adolescents. They have a low sense of identification with traditional culture due to Western colonialization, yet have difficulties relating to mainstream Canadian culture. Research has shown that having more connections with traditional culture predicts lower suicide rates. Research has found that the more that First Nation communities can connect with their cultural history, the lower their suicide rates are. The communities that have the greatest number of connections have suicide rates that are comparable with those of the Canadian average. These connections include having one's own political body, maintaining control over educational services, cultural facilities that promote a community's cultural history, having its own policing or law enforcement organization, whether a community is negotiating a claim to territorial land. The more these indicators are present, the lower the suicide rate. And this topic here, I feel like I could teach an entire course on this, and there's a lot to unpack here, but we're kind of running long, so just kind of briefly stated. We've covered this a little bit in this class when we talked about the impact of the loss of kind of culture and kind of colonial practices on developmental outcome in indigenous tribes. But we talked about Aboriginal tribes in Australia. But this is kind of a universal kind of idea across indigenous tribes and the Western world, or more globally. In this case here, we're talking about First Nations in Canada, wherein adolescents of indigenous adolescents are at 5 times have suicide rates, I should say, 5 times that of other Canadians, and kind of having a low sense of identification with traditional culture, while also not having having difficulty relating to mainstream cultural Canadian culture, contributing to higher rates of suicide. But more broadly, kind of the idea here is that losing one's cultural narrative and kind of new pressures of modern society, putting people at risk of poor developmental outcomes. So kind of the idea here in the West is, you have your own specific kind of narrative of your life. You have your own autobiography that you keep, that you kind of keep internally. But also there's these larger kind of cultural narrative, these country and also or countrywide narratives, where we have kind of an understanding of what our social role is within this country, what are the certain assumptions, the promises made of a country, of a culture, and kind of how to act within that culture. And the idea is that when you kind of strip away those assumptions are proven false, or they're destroyed through violent means and displacement. That kind of contributes to kind of a loss of self. And a loss of self-connected, not just within, and I should say actually self being either the independent self and or kind of the interdependent self. So kind of loss of yourself as a person with particular properties that you're pursuing on an individual level, but also kind of your loss of kind of interconnection to your community. And by losing both those things, or maybe one more than the other, you're ultimately losing these protective factors that allowed individuals to kind of navigate the inevitable tragedies and stressors that occur within an individual's lifespan. And I should note that it's not just suicide rates, but also rates of addiction in Canadian Indigenous populations have being extremely high and being far more high than the Canadian average. And you also see this in the U.S. with rates of alcoholism. So kind of just a way to kind of deal with the pain of losing those cultural those connections, that cultural narrative, that individual narrative, that you kind of exist, that there's a purpose to life, contributing to kind of increases of addiction and suicide rates. And arguably, you can kind of see similar things in non-Indigenous individuals or across kind of like the Western world, or specifically kind of the United States, wherein kind of these larger shifts kind of we've kind of reached this point of history wherein wealth kind of stagnating for decades, really not a lot of vision of kind of how to get through this and like really alternative solutions, and thus kind of those cultural narratives of the United States kind of being violated for newer generations, millennials and Zoomers. That's kind of increased, possibly contributing to kind of this increase of kind of like anxiety of fearfulness about what's happening in the world. These big and just not just wealth, obviously, but obviously looming climate change, which obviously already here, but what prospects of it getting worse. So kind of those violations, those letdowns of a cultural narrative, contributing to probably the onset and higher rates of anxiety disorders in the United States. It's just another example. But also, as you can see here, for indigenous individuals, and again, kind of going back to the idea that these developmental outcomes are not just predicated on those very small individual kind of psychological factors, those peer-to-peer relationships, or just really the self, or maybe just in a household, for example, in a nuclear family kind of conceptualized in the West. But you can see here that these larger macro community, these collective solutions driving individual developmental outcomes. So having control over like politics, education, territorial sovereignty, having connection to cultural history. So these larger collectivist group kind of solidarity of kind of culture coming together to buffer and to increase the likelihood of positive developmental outcomes. And at the same time, we see these larger cultural trends across the world of individualism, thus kind of losing this ability of this collective action, alongside the idea that really nothing can really change, and that there really isn't this kind of agency that exists among individuals, kind of this really stagnation period that we're in, kind of being a cultural theme of the times, possibly contributing to the rates of suicide rates in opioid abuse and kind of record-breaking opioid addiction deaths, and just addiction deaths more generally in the United States. New data kind of suggesting that opioid addiction kind of reaching another record high. So kind of that's just kind of a general overview. Long story, less long. Jumping ahead a little bit, treating mental illnesses cross-culturally. Just as presentation and prevalence of psychological disorders vary across cultures, the same goes for how the disorders are treated. There is a tradition in the West of patients seeing a therapist and verbalizing their feelings and problems. This is likely rooted in the Western emphasis on self-expression and de-emphasizing other expectations and social roles, and ignores non-Western ideas of not attending to emotions and private feelings, and that people don't actually talk about their troubles to others. Let's get into some specifics. Social support. There is great cultural variation in coping and seeking support. Research has suggested that social support is good for one's health, regardless of cultural background, but the way people seek and provide social support may differ. East Asians are less likely than white Americans to actively seek help from others. This is due to concerns about how this will disrupt relationships with others. Instead, they rely on implicit social support, that is, finding emotional comfort in those close relationships, e.g., reminding themselves of the close relationships that they have. Whereas white Americans show less stress when they seek help, Asian Americans show less stress when they think about their relationships. Other examples: East Asians tend to offer problem-solving support more than emotional support. Russians are more likely than North Americans to provide problem-focused support. Americans tend to provide emotional support involving positive feelings, whereas Germans focus more evenly on both positive and negative feelings. This may explain why East Asians tend to seek professional mental health treatment less than Westerners do. Then I want to jump ahead one more slide before I kind of doing a breakdown of this. Psychotherapy and other methods. Western treatment traditions can be traced back to Freudian times. Freud thought that psychological problems were best treated by exploring people's memories and experiences because such problems were believed to be rooted in people's conflicts and fears at an unconscious level. And the therapist should then interpret those experiences and memories. Carl Rogers, another psychologist, introduced the client-centered approach, kind of straightforward. We're not going to review that in too much detail, but putting the client first. Other kinds of psychotherapeutic approaches have since been developed as well. Cognitive behavioral therapy involves restructuring unhealthy thoughts by identifying dysfunctional biases and alleviating negative reactions through controlled exposure. A common thread running through all the different therapy options is the client's ability to engage in a psychological discourse grounded in shared cultural meanings. There may be implicit emphasis on understanding the individual, his or her self-discovery, and his or her cognitive biases. So kind of globally what we have here is that there's just different cultural variation in coping and kind of seeking support, with East Asians being less likely to seek explicit help from mental health treatment professionals than Americans do. But they seek different ways to kind of cope and seek support. And as laid out, kind of implicit social support, wherein that they're finding emotional comfort within their close relationships and by kind of interacting within those family dynamics, that in-group, those kind of interactions, reminding themselves of kind of the close relationships that they have, that they are kind of within a unit. People are kind to them. They should be kind to other people, and kind of just like this sense of belonging and comfort that comes alongside that within that in group, versus this idea that kind of this Freudian approach, or kind of the approach that, and just in general in the U.S., that we have an understanding that you just go to a therapist, you talk about yourself, you're really focused on your self-discovery, uncovering your cognitive bias about yourself, or kind of interpreting the world. This kind of approach is really this kind of literally kind of client-centered approach, and really focus on emotional support contains or could contain specific particular implicit biases of like what is sound mental health and how do you go about dealing with kind of disturbances to your mental health. And you can even see this compared to other Europeans, where Americans tend to provide emotional support involving purely positive feelings, like a very hyper focus on positivity, where some other European countries, such as Germany, kind of giving a more even approach of both positive and negative emotions when kind of seeking support. In non-Western cultures, healing practices are performed very differently. One study examined indigenous healing practices used in 16 societies in Africa, Asia, South America, the Middle East, and the Caribbean. Two models of healing emerged in these places outside the West. One of the most common practices is the role of families. Family members were most important in resolving mental health problems. They shared the problem with the individual and were a key source of guidance, especially elder members. They also share the stigma and blame associated with whatever mental illness the individual has. Second, involves spiritualism and religion, which incorporates traditional healers such as shamans and sorcerers. Mental illness is perceived as rooted in underlying spiritual problems or relationship with God or gods that went awry. Yoruba and West Africa view the person as the union of body, mind/soul, and inner head, each of which comes into existence by specific gods. So kind of looking at two of the main themes that emerge while looking at 16 different societies across multiple continents. The first being kind of the role of the family, and this should be pretty consistent, familiar to you with all the rest of the material from this book. So kind of this interdependent self, this collective notion, working with the family. So in this case, obviously, family is going to be important when resolving mental health problems, and versus kind of a Freudian approach or a kind of a very just individual focused approach of the U.S., but kind of like West, more globally, where you're focused on self-discovery and understanding the individual and the essence of an unchanging, unalterable individual, and how to kind of restructure your individual biases of how you're interacting with the world. Kind of not being consistent with these particular models of healing found outside the West. And also kind of this spiritual component or this religious component, wherein kind of spiritual problems or mental health problems thought to be associated with particular spirits and or kind of God or gods. So kind of this religious component. So you can imagine kind of putting an individual from a Western African, a Yoruba individual in a Freudian, classic Freudian setting, and talking about whatever it is they're talking about, and that's really not being applicable to the healing practices that individual practices in their culture. And so not only is it potentially not helpful, but it can also be quite harmful as well. And in the interest of time skipping ahead, given differences in prevalence rates and culturally specific presentations of mental disorders, matching treatment to the culture seems crucial. One concern that has been raised is whether Western mental health treatments may sometimes do more harm than good. It's been argued that anorexia did not exist in the same form in Hong Kong until it was imported there. Post-traumatic stress disorder was not a big problem in Sri Lanka after the 2014 tsunami until Western aid workers insisted that they must be suffering from it. And this is a huge problem within trauma research and kind of which is my background field, and kind of the general idea here is that, again, Westerners, kind of these NGOs, these aid workers coming to communities and where there's a war, where there's a natural disaster, or whatever, a hurricane or a tsunami, earthquake, whatever, and then kind of importing their understandings of mental health and not just kind of the onset of it, but what's driving it and what do you do to fix it. And in fact, kind of as stated, kind of bringing this individualized, self-centered kind of approach, a common Western approach to mental health. To these individuals who had just suffered a traumatic experience, and kind of that approach actually increasing rates of, in the Sri Lankan example, PTSD, but also other psychological disorders. So literally actually doing harm instead of aiding. So it's very important to understand that this hashtag just get therapy, do this one specific type of therapy is not this universal cure-all for individuals across all cultures, and in fact it can be quite harmful in particular circumstances, because if you can imagine that individual that being in a therapist room by yourself talking to a random or kind of a Western therapist, what's really kind of going on is you're kind of separating an individual from their religion and or family, which can create even additional stressors by stripping people away from those buffering effects, those protective factors found within the family and their religion. So thus kind of you're stripping, in a key moment of kind of like trauma, you're taking them away from kind of their most protective factors found within their culture, thus kind of making it even worse. Or arguably creating psychological disorders that did not previously exist within a specific culture, or at least maybe symptoms associated with particular psychological disorders. Multicultural therapeutic settings. Therapists in multicultural settings frequently have clients with different cultural understandings of mental health, treatment, and symptoms. Therapists who work with clients from different cultural backgrounds strive for cultural competence. Recognize that their own culture influences so that they are aware of their own thought processes when dealing with clients, so they can monitor their own personal preferences, interpretations, and projections, which will be relevant with interacting with clients from different backgrounds from themselves. Develop knowledge about the client's cultural background so that they can better understand the kinds of expectations that the client likely has for counseling relationships, and develop skills to intervene in the therapy sessions in a way that is culturally sensitive and relevant. Therapists need to be flexible and adapt to the individual needs of the client, as not everyone is typical of his or her culture, and several cultural identities may intersect in some people. As stated, the idea here is that when working with people from different cultures, you should strive for cultural competency. So understanding that culture, understanding your own, so you can understand your own biases, your own interpretations and projections of things, and then understanding their expectations for therapy or kind of approaches to therapy and kind of their own or individuals from someone else's cultures, understanding of the world and expectations. But also at the same time, understanding that not everybody is exactly the same within a culture, and that there's, of course, variability within culture. And obviously, also within cultures, people have multiple identities and different groups that they belong to, which may intersect and contribute to different unique understandings of the world. The Cultural Consultation Service is an interdisciplinary approach involving many different mental health professions. The most current and comprehensive approach: psychiatrists, psychologists, social workers, psychiatric nurses, medical anthropologists, and trainees from different disciplines meet regularly to discuss cases referred to them by therapists who need expert advice working with multicultural clients. The group discusses particular cases of multicultural clients to tackle a variety of issues from therapists would generally not recognize or be ready to handle, such as stresses from migration or exposure to torture or war. In the vast majority of cases, therapists report the consultation was helpful in helping them with their clients. However, the service can be prohibitively expensive. So kind of the idea here is that this interdisciplinary approach, where we have all these different people from different professions and different cultures coming together to kind of give the most up-to-date and comprehensive current understanding of how to deal with certain multicultural clients and clients who come from unique backgrounds, not typically shown in the United States, for example. So extreme exposure to torture, to war, to migration, great migrations across continents by foot, not very common of Americans. So kind of how to deal with those variety of issues that are not typical in most Americans is through this kind of interdisciplinary service. One big issue with this is that this service is very expensive, thus a significant limitation, and really one possible approach to kind of addressing some of these issues with multicultural therapeutic settings or clients would be to how to deal with the fact that this is prohibitively expensive. In summary, some psychological disorders are culture bound, while others are universally identifiable. Even the same psychological disorder can manifest and be experienced in different ways in different cultures. And treatments for psychological disorders differ across cultures, and therapists should strive for cultural competence as they treat diverse clients in multicultural settings. And with that, we are done for the semester. I want to take this opportunity to thank everyone so much for your hard work this semester. I really appreciate it. I hope this course was enjoyable. I appreciate you listening to me blog on about stuff for hours on end. And again, I very much appreciate all your work you did with your discussions, your quizzes, your interaction with this course. I have several people have told me that they've learned a lot from their peers, just reading their peer discussions. So just, thank you so much for that. Without participation in this course, it would be a lot more boring. So I appreciate all your hard work this semester. If you ever need to reach out to me for any reason, feel free to do so. And yeah, I hope you all have a great break. And I hope that I was able to help you kind of reconceptualize psychology for you and kind of introduce you to new cultures, and different, as I stated, kind of different interpretations and understanding of human behavior, contributions to human behavior, and kind of these structures, and the importance of these economics, politics, cultures, historical eras on human development and cross-cultural differences. So again, thank you so much, everyone. If you ever need anything, reach out to me. Thanks a lot. Bye.